Good morning, everybody. Welcome again to another webinar brought to you by the National Institute for Occupational Health, the NIOH, a specialized division of the National Health Laboratory Services. And we are today dealing with a topic called the ethical dilemmas in the workplace during COVID-19. And we have called upon people who are specialists in their different fields that plays key roles within our workplaces to ensure that we as workers, as fellow employees, are safe within the workplace, and some of the challenges that were experienced in the recent years with regard to the big pandemic we faced and that has affected us in the workplace as well. I have the pleasure of having 5 very key speakers on board. That's Sister Ntokozo Shishi, Dr. Jan Naper, as well as Professor Cass Bardonos, Mr. Yup Jube, as well as Dr. Frank Fox. And because we've got a jam-packed program for today within the hour that we have, we will be asking you to please pose any key critical questions you have to our email address info@nih.ac.za, because we are unable to fit in a proper Q&A session for this particular webinar. And without further delay, I'm going to ask our first speaker to unmute and to share her slides, and that is Sister Ntokozo Shishi. She's an occupational health nursing practitioner in the food packaging industry. You have seen her bio as part of the pre-webinar slides, and those slides will also be available when the video is on YouTube for you, as well as when you receive the PowerPoint slides through our email post-webinar. Welcome. Thank you very much, Ntokozo, for joining us and taking the time. If you could unmute and then perhaps just proceed with your PowerPoint presentation. Over to you.
Good morning, everyone. Can you hear me clearly, Ashraf? If you can give me a thumbs
Very
up.
well, yes. If you could just move your microphone a bit closer as well, and then open your PowerPoint. Thank you very much. Over to you.
Okay, is it better now, the sound?
That sounds better. Thank you.
Okay, let me try and share on my side. Um, Okay, can you see my slides?
Not yet. Have you used the share function?
Yes, yes. I don't know,
Just
perhaps if you can share on your side
okay. I
for
will
the
do
sake
that.
of time, because
Yeah,
it seems
uh,
jammed.
you're welcome.
While we are opening the slides, I would like to take this opportunity to greet all the colleagues that have joined the webinar and thank NIOH for this opportunity to present on this topic. Okay,
Okay,
I
so
can see
quick
the
question.
slides.
Can you see the slides? Is it in the full
Okay,
screen or do you see the notes on the side?
I see the full screen, which is
Okay,
fine.
great. Just say next and I will move the slides for you. Please proceed.
Okay.
Thank you.
So I'm in occupational health nurse, as explained in the intro. I'll be presenting my perspective on the ethical dilemmas encountered during COVID-19 in the industry that I work in, which is mainly food packaging. If you can have the next slide, please. And okay, so the food industry, as you know, is a key industry in our food supply chain. Uh, During the COVID period, we found ourselves in a situation where we had to make tough decisions. Do we provide food to the nations or do we protect our employees? This in itself was an ethical dilemma for the industry. If you can move on, please. So before I get into the presentation, we need to define what ethical dilemmas are. There are numerous definitions. One definition says it's a situation where an agent stands under two conflicting requirements, none of which overrides the other. Another definition is a situation that cannot be solved. Decisions between the two options may be morally plausible, but are equally problematic due to circumstances. In an occupational health nurse perspective or setting, it's a situation where the OH practitioner must make a choice between competing values and knowing that no matter what choice you make, there will be consequences. As such, that the World Health Organization actually anticipated ethical dilemmas. We are aware that there was a working group on ethics and COVID-19. That was formulated by the World Health Organization to address various type of situations that can cause dilemmas to arise. Situations like research, how do we proceed with research, rolling out of vaccines, and the guidelines on how to manage COVID-19. Next slide, please. So in terms of looking at ethical dilemmas from an occupational health nurse's perspective, I looked at four key uh, P's or P's. The one P is purpose, people, practitioner, and principle. If you can go to the next slide, please. Okay. Oh, please go back. Just show one at a time. So when we speak about purpose, this speaks to the organization. The organization that are in the food industry are organizations that have certain purposes. They have missions, they have values, they have certain promises that they make to stakeholders and also to their customers. All of a sudden, these organizations were suddenly deemed as essential industry. Next, please. The dilemmas that they encountered are the commitment to purpose or your mission, which was in conflict with the requirement to keep our employees safe. Next, please. Next, please. The other dilemma was the perception that these industries were prioritizing production over employee well-being and safety. Next, please. And then we also found that another dilemma was that predominantly white collar workers were working remotely, yet the blue collar workers were expected to come to work every day as essential service workers. Next, please. Next, please. There was also the requirement to balance isolation and quarantine requirements versus the production demands. So you found that a big group of employees had to quarantine, yet there was still a requirement to provide food and make it available to customers, to communities during the period of COVID. Next, please. Um, the other dilemma that presented was the risk to business reputation, in that if something were to go wrong, in case, for example, cluster outbreaks, if there were COVID-19 related death, these this information was publicized in the media, and it sort of dented some organizations' reputation. There was a perception that they were not complying 100% with COVID requirements. Next, please. Next, 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 next. Okay, that's fine. So what did the industry need to do to mitigate or deal with these dilemmas? It was very important that there was clear COVID-19 knowledge and expertise. They also had to implement robust safety measures and provide continual awareness training to all stakeholders, especially the employees that were now essential workers. And some companies went to the extent of providing support, additional support resources like transport, food packs, means to sort of get quick medical assistance. And the other important way to mitigate the challenges that presented with the dilemmas was to provide accurate and timely communication. We all know that the pandemic was moving very fast. There were changes quite frequently. So the organization had to keep up as well. Next slide, please. Next, please. Next. Just show all of them, please. Next, next. That's fine. Thank you. So in terms of people, the dilemmas that were presented by people, employees, communities, etc. So in the food industry, people were committed. They understood the position or the mandate of the business, and they had to balance the requirement to be at work and their own personal safety. Some expect employees who are vulnerable workers were also expected to be on site. There was also situations where employees were not adhering to COVID-19 precautions outside work. During work hours, they were 100% compliant. Outside of work, they did not comply. The other dilemma was non-disclosure of exposure because people were scared to be isolated in their homes, especially the people that are living on their own. All of a sudden, they contract COVID and we expect them to be isolating on their own or at facilities that they are not familiar with. Non-disclosure as well was a problem in that some employees did not want to disclose exposure because they feared the stigma of COVID-19, especially in the infancy of the pandemic. There was also dilemmas relating to vaccination, refusal. Some industries made it voluntary, some industries made it mandatory. So an example of a people-related dilemma would be like, for example, a specialist over the age of 60 with chronic conditions deemed to be an essential worker and is compelled to come to work at the peak of COVID-19 because of their expertise. Next, please. And another example is if you were to state fully the dilemma, employees prioritizing production despite the potential risk of employees' exposure to COVID-19. So how did we mitigate this ethical dilemma, or how do we address it? Again, COVID-19 awareness, peer coaching, strict compliance and use of PPE, providing EAP or mental well-being support during this time, clearly explaining the purpose and the benefits of vaccination, providing employees with additional supports and appreciation. Next, please. Next, please. The principles of ethical dilemmas. So I won't go through these point by point, but I think there were dilemmas that arose relating to autonomy. As a nurse, as an occupational health nurse, you had to make decisions or on your own, and in industry, most of us have the authority to make such decisions relating to management of COVID-19 and our employees. Accountability. So our actions also had to be within our scope of practice, and we took full ownership of the decisions that we made during this period. Beneficence. We know that is about ensuring that there's more benefits versus risk. Non-maleficent speaks to preventing harm and doing no harm. Justice, decisions around COVID-19 had to be fact-based. We received statistics that guided us on how bad or how critical the pandemic was and at what stage we're in. So we had to make sure that we communicated this clearly to our stakeholders, especially our managers and employees. Fidelity speaks to honesty and loyalty, and veracity speaks to complete openness and honesty, even if the truth might be unpleasant, as it was at times with COVID-19. Next, please. Next, please. And finally, the last person, or the last P, is the practitioner, being asked the OH NPs. So the dilemmas we encountered was the conflicts between the interests of the organization and our own personal safety. Also, learning on the go. Suddenly, we were deemed as COVID-19 experts, and we had to deliver knowledge that we ourselves were not familiar with. There was also the expectation to be accessible 24/7. Essential work led to potential exposure of our families to COVID-19, and also balancing the requirement to keep confidential certain information, and also balance that with employer requirements of disclosure during the COVID-19. Next, please. Next. Okay, that is fine. If you can just go back, please. Okay, so how then did we mitigate these ethical dilemmas? Again, COVID-19 knowledge, have that attitude of learning on the go. Collaboration was key, and also developing resilience as occupational health practitioner was key, and also self-care and self-worth. We realized that it's very important to know your worth as an occupational health practitioner. And lastly, it's important to embrace transformation. We know that communication was digital. We used phones, we used emails, we communicated remotely. So it was key that we all embraced the digital technology. And lastly, next slide, please. Next slide, please. I know that it was rushed, but that was in a nutshell my experience of the ethical dilemmas. I hope it was clear. I would like to take this opportunity to thank NEDLAC, and also the resources that we used in compiling this brief presentation. Thank you very much, Ashraf.
Thank you very much for that. And that was Sister Ntokozo Sishi giving us the occupational health nursing practitioner's perspective. We are now going to immediately go over to Dr. Jan Lapierre, who's an occupational medicine doctor and independent occupational safety consultant within the certain specialization and social law, social labor law. Over to you, Dr. Lapierre.
Thank you, Ashraf, and good morning, everybody. Thank you to NIOH for inviting me. It's always impressive to be called by your colleagues to come and explain your side of the story. 10 minutes isn't much, and I must thank my colleague for covering a lot of theory already now. That gives me a little bit more time to go into the specific dilemmas that occupational medical practitioners we're dealing with. Just a short reminder, we had this very acute thing that came upon us end of 31st of December 2019, where there was this cluster of pneumonia cases in China. And then very quickly it evolved that it wasn't a zoonosis, but it was a human-to-human transmission. And by the 11th of March, the World Health Organization had already declared that we had a pandemic. to which our government on the 15th of March declared the state of disaster. And so worldwide, what happened is the people we trust the least, i.e. politicians, suddenly became almighty persons. So we had uncertainty, we had ongoing fear, we had new and rapidly changing laws and regulations and guidelines. And so we had to work within that uncertainty, as you heard from my colleague sister a minute ago. Uncertainty was the only certainty you had. And so I identified that during the course of this whole pandemic, until it was kind of declared over on the 5th of April and our state of disaster was taken away in 2022, that we had nine big impacts. First was the total lockdown and movement restriction, the closure of non-essential businesses, then the remote work and essential operations, immediately the financial support measures. Then we came to the hope to return to work phase, and then throughout we had to adapt health and safety protocols, adjust HR policies. Then came the final relief. The reason why we out of it is the vaccination rollout, which then allows us to go back to our normal case. So eventually originally NIOH already doubted what is happening here. And so on the 26th of August, Ashraf, you held this seminar where we looked at the legal and ethical impacts as we were in the middle of it. And I think we then identified that we had tested law and we had tested ethics and we had untested. And by then we already had a lot of these disaster regulations, directives. And so the main question was, is it really law? Can it overrule existing law? Officials came up with the weirdest of things. Do they really have that authority? And our body ruling, the Health Professions Council, has got quite strict ethical rules and allows an ethical reasoning within a framework. But then it also says, you might have to go out of the box. You might have to depart from the established procedures. And so this is what we really had to do. And for my talk, I essentially will look at two large things. There's a shift in ethics and a conflict of the OMP duties. So what immediately happened is there was a shift from clinical to pandemic ethics, or from medical ethics to public health ethics. And so, as Sister alluded to just now, some of our basic values, just as justice, where a healthcare practitioner must treat all individuals in an impartial, fair, and just and equal manner. So for the clinicians, it was who gets the ventilator. For us, right in the beginning, it was, can we allow a Chinese businessman in our meetings? Can we allow our employees to go to China? Here in the Eastern Cape with the motor trade, that's a common travel. And then later on, other things started happening. Employers started doing weird things. We may have some HR managers listening to this. So some of you made our lives very difficult by, for instance, requiring contractors to have a PCR test before they were allowed to on site, or other weird things where when a person had COVID, was completely healed, then had to have a negative PCR test before they were allowed to return to work. Patient autonomy and self-determination was heavily assaulted. It's automatically assaulted due to the notifiable conditions, because they in a way, quarantine and isolation, compulsory testing protocols, compulsory management protocols, they take over. But in the DMA regulation, it was taken one step further, and it was taken weirdly further, for instance, by the Minister of Health, who on a media briefing suddenly decided that we require now that all sudden deaths and those that occur at home must have specimens taken for COVID-19. So you had a form of autopsy even without your consent, even without an application to the High Court, as our regulation said. And so we had to deal with these weird ones amongst the logical ones too. Then confidentiality suddenly became a problem, because there was an overriding legal obligation to disclosure because of the notifiability of the condition. And at a later stage, there was also a duty on employers to report a whole lot of personal health information on employees. And then the question was, obviously, the OMP is the person who holds most of that information together with the occupational nurse and the occupational clinic. And it was imputed to them to now suddenly start divulging this information, whereas we had no consent for the employees, from the employees to do this. And these rules and and things came out as disaster management guidelines and rules and regulations. So quite difficult to know whether you were doing the right thing there. And then, as Sister also alluded to, you know, our best interest on the well-being of patients. That's probably more in the primary care, where you saw that telehealth came up. Some general practitioners, some medical practitioners wouldn't see patients if they didn't have a negative C19 test. And, you know, vulnerable employees, particularly OMPs, you know, would even refuse to clinically see patients because of the risk that was there. So we look at that was the ethical assault that we had and we had to deal with. And we had to look at the conflict of the OMP duties. Now, OMP duties got essentially four classes of duties: natural duties owed to all people, professional moral duties, institutional duties, particularly as an OMP, because we're employed in an institution, and then legal duties. None of these duties are absolute. And, you know, in our case, you know, different duties may prescribe opposite directions and actions. And that's our classical, we deal with that on a daily basis, the dual loyalty versus the employee and the employer requirement. The Medical Association says that during the COVID-19 pandemic, these duties remain and are heightened. Society puts a greater expectation on doctors during this challenging time. So our duties, whilst being affronted, were actually enforced. And then what there also was, and what there also is a reciprocal duty obligation to doctors. In other words, in a pandemic like this, doctors need kind of special treatments so as to minimize their infection. They get priority to medical care, to COVID vaccine. They get assistance to their family members. And you know, every patient has got a duty to minimize the spread on that one. And management also has got a leadership and accountability to ensure that the doctors and the medical sector, this is not just for the doctors, this is for everybody in the medical sector, all those heroes that were there. And so where the first assault came, obviously, on the moral duty of care, where there's, you know, the collective duty, as I mentioned earlier on, you know, suddenly the employer's request on testing and communication of information is imputed to the OMP. But at the South African Society of Occupational Medicine, we had a number of questions on how to deal with the severe high-risk comorbid employee who refuses sick leave because there's no more money for sick leave. Then should employees with comorbidities be exempted from coming to the workplace? All of them, even those that can't afford it. And so questions like, is it compulsory that employees that have comorbidities come with a doctor's note about their condition? So is it sufficient just to say to the employer, this person's got diabetes, or must it also say how well it's controlled? And as Sister said earlier on, a lot of blue-collar workers could not work from home. Another duty that was under pressure was the duty to colleagues. Obviously, in a pandemic and in a notifiable medical condition, the cradle-to-grave management of a patient that's suspected is managed through rules and regulations, and every doctor has to follow those regulations. And many doctors didn't, and so you would have people coming back again with a sick certificate that said flu, but that person would never have been tested for COVID. And obviously, our ethical balance then is between not casting reflections on the management of our colleague, of the employee, versus, you know, whether that doctor was actually acting in the best interest of his patients. I need say nothing about the OMPs and the doctors, particularly the private doctors of certain sectors who were involved in the ivermectin saga and who allowed a poison to be distributed to sick patients or as prevention to patients. And then even the reciprocal duties of doctors were being assaulted. There was a case, you remember, where the employer said, well, you know, we're not going to give special PPE to healthcare workers because you have to use it in your own personal capacity in any case. And obviously that was in flagrant conflict with what the occupational health and safety laws and the NIOH clinical management of COVID said, that the medical practitioners must be provided with the right equipment. So in conclusion, there were many heroes, but I want to salute my colleagues, OMPs, because they're also heroes. You know, during the full lockdown, we had to get the information. We had to get the information for the employees, for the employer, and we also had to get all the information prepared for reopening, because it was impossible to stay locked down. So that was a hard craft. And as Sister said, we had to become experts overnight in something that you became an expert at every day by restudying and rechecking all the things that were happening in a sphere where there were colleagues publishing false information also. Then upon reopening, we had to implement whatever we had established and then change it again, because everything changed. We had to deal with the new rules. Often you'd come to work and an HR manager already read the government gazette before you, and things had changed. And so you had to make sure that all that came into place. You had to make difficult decisions, like we never thought of reusing a FFP2 mask for several days. And then suddenly it had come up like this. And then at the last phase, we had the vaccine. We had to get the vaccine into the workplace. We had to assist employers with the value of the vaccination, and we had to assist with those who had compulsory vaccination, and then the end up of the refusals. So that's in short what we're dealing with during the pandemic. Thank you, Ashraf.
Thank you. That was Dr. Jan Napier, our occupational medicine practitioner, doctor, with great experience. And again, doctors tell you we have reached over 720 attendees for this particular session. Very popular. We've just had Sister Ntokozo Sishi before him. And our next speaker is Professor Cass Bardenos, an occupational hygienist. And we will get a perspective from the occupational hygienist perspective. I'm going to ask Prof to open his microphone and share his slides and maximize it for us, please, and then to proceed immediately. I'm also going to ask our attendees the indulgence. We may need to use a few minutes longer than our 11 o'clock closing time. Over to you, Prof.
Thank you very much, Astrid. Can everybody hear and see me?
We can hear you clearly, yes, and we can see your slides.
Perfect. Thank you for the invitation again, and to share with our colleagues, you know, the experience from occupational hygiene perspective during the COVID pandemic. Let's quickly move this forward. There we go. So, as you know, or might know, occupational hygiene is the discipline of anticipating, recognizing, evaluating, and controlling health hazards in the work environment. And this actually includes biological risks in the workplace, such COVID. We are guided by our code of ethics, the Southern African Institute of Occupational Hygiene's code of ethics, that requires us to carry out the practice of occupational hygiene according to the highest moral standards, serving the occupational health needs of workers, conducting our profession affairs with integrity and impartially, protecting the confidentiality of workers, maintaining the competencies necessary to provide the professional service, ensuring and maintaining full professional independency, and honoring our colleagues at times and protecting their integrity. So for the hygienists, there was two key dilemmas during COVID. The first was the balance between worker safety and business operations. And I think the sister also covered earlier. The hygienists had to ensure the safety and the well-being of workers while also considering the impact of business operations. This balance proved to be quite challenging, especially when implementing strict safety measures that affect production. The second key dilemma was actually prioritizing of limited resources, like all others, and also like Dr. has explained before. During the pandemic, there has been a scarcity of resources such as PPE and testing kits, occupational hygienists and other health and safety professionals had to make ethical decisions on how to allocate those limited resources to protect workers effectively. So the first weeks were actually chaotic, and I think we all can recall what happened those first few weeks. And I think the critical pivot there for us was on the 27th of March when we went into lockdown 5. And we've had this declaration or this reference to essential services, and essential services was sort of highlighted or defined as those services that are linked to the means of food, medicine, healthcare, energy, fuel, etc. The regulation at the time requires us, if your business is considered essential, you must operate in a way that minimizes risk of COVID-19 transmissions. Businesses therefore should minimize or eliminate, if not possible, physical interaction among staff and with and between customers, ensure appropriate health, hygiene and safety measures are in place, and restrict activity to only what is essential during that period. The question then came up, how do we actually protect workers against COVID-19 in the workplace in these conditions? And there was a requirement for workplace health or exposure transmission assessments, workplace measures, control measurements. The challenge we've got, the first challenge and the first ethical dilemma the hygienists had to deal with is, as occupational hygienists, we were never recognized as essential workers or as essential services. At the time, occupational hygienists were required to go out into the field, even during lockdown 5, to undertake risk assessments. I remember some of my colleagues has been the first to actually went out to some of the national laboratories to do COVID risk assessments. And this was done without being classified or recognized as essential workers. And these are all required permits for travel, etc., became quite problematic. At the time, the hygienists did actually apply to have this revised and to have occupational hygienists recognized as essential workers, but this never actually received a support from government and from the Department of Health. And when it even got to the vaccination phase, our hygienists again had to stand back in the queue because we did not get recognized as essential healthcare workers, although these guys and my colleagues spent a lot of time in the field putting themselves at risk. So this was, I think, a real dilemma for the hygienists, doing all this work, putting themselves at risk, but not getting recognition for doing this work. So what does it look like? This was an unknown risk. We had social media. You will remember the first pictures that came out of Italy, of which I've got an example there. We didn't know what we are dealing with. Occupational hygienists are trained and they do practice and consider biological hazards, but in the general training of our occupational hygienists and in their day-to-day practices, this is not really a big thing on the radar. And suddenly we've got this unknown thing. And the hygienists had to ask themselves, how do we actually deal with the unknown whilst not putting oneself at risk? And I remember several of my colleagues, as I said, going out there for those initial assessments and so forth. They were quite scared because they're actually putting themselves in harm's way by doing assessments on something they actually don't know. So that was, I think, the second biggest, or the second dilemma the hygienists had to deal with, is the unknown. Access to knowledge at the early stages were quite scarce. Access to facilities was quite a challenge. There was a general lack of tool and awareness materials, reference materials, and though there was a requirement by law to create a COVID-19 safe work environment, there was uncertainty in terms of what does it actually look like. And the hygienists out in the field struggled with a third ethical dilemma, which I just call the fear of missing something. Going out there, doing risk assessments and asking ourselves, are we missing something? And what if I do my risk assessment and I've actually overlooked something and this turned into an outbreak? I think all of us had to cover with this, or had to deal with this through the pandemic. the challenge between science, myth, and the unknown. Some of the initial responses include temperature screening. We all can remember having temperature sensors and temperature instrumentation put against our head. You know, yes, whilst the science were there to support it, the general practice out there were very, very spotty. You know, the way it was done, the way these instruments was handled, the environment in what it was handled. So it pointed the challenge: how do we actually do things, or required to do things, or oversee measures that we know in science are actually failed? We had to deal with things like spray tunnels. The notion of using ultraviolet lights, you know, disinfecting groceries, using hand sanitizer only as opposed to water and soap. And there's many more. And I think, as Dr. Jan also said, you know, we've had all this coming to us, and how do we actually respond to what is science, what is myth, and what is the unknown? So the fourth moral dilemma I want to outline here was the access to latest scientific research and information and implying that knowledge. Our hygienists had to stay informed about evidence-based preventions all of the time. And we had to adapt to new information and adjust preventing measures accordingly. And as you know, these have really changed almost on a daily basis in the beginning of the pandemic. This is probably my favorite dilemma I think we've all dealt with, is the confusion that reigned around respirators, masks, and face covering. And I think we all can justify there was a lot of confusion, a lot of misinformation, and a lot of uncertainties. And I don't even want to talk about the corruption that went along with this. But workplace protection versus workplace protection of the public was a big topic at the time. We had this N95, KN95, FFP3 debate, you know, where N95 is a mask that gets certified in the US towards NIOH US standards, to having a 95% filtration efficiency. And suddenly this was dumped into or onto South Africa, that we need to or can only consider an American standard. And it took quite a while to get users and suppliers around the notion that this is actually a US standard, and we've got our own standards in terms of respiratory protection and so forth. But it was total confusion out there. We had the confusion around exhalation valves that actually just, you know, almost made the mask non-existing. Inflated cost and availability of masks, lack of user public guidance and training, and cleaning maintenance replacement, the use of field sheets, face shields, and so forth. You know, so in principle, you know, our occupational hygienists are trained to implement respiratory protection programs. They are specialists in the management of respiratory protection, the selection thereof, the limitations thereof, and how do we use these. And they are specifically trained to manage biological risks across all work contexts, including facial or respiratory protection. However, the dilemma we're dealing with here, the South African hygienist and SIO, which is South African Institute of Occupational Hygiene, were not allowed to be part of the front of advising on the selection and use of the appropriate respirators, masks, or any type of face coverings. No formal advice on the topic was actually also published by SIO, which I think personally was a failure of our institute. Indoor air quality and ventilation. The critical contribution of good indoor air quality and ventilation in workplaces to prevent transmission was initially not recognized. But that was part of the bigger problem, I believe, and which is probably a webinar its own, in terms of a poor understanding of the basic principles of the hierarchy of controls or its applicability to the management of COVID in the workplace. The failure to use systematic and proven approaches to the management of risk in the strategy and approaches resulted in gaps in the consideration of how to manage this pandemic risks. Again, as with RPE, our hygienists are specialists in the management of indoor air quality and ventilation, but again, the dilemma was that South African occupational hygienists and SIO were not allowed to be at the front of advising on indoor air quality and building ventilation. SIO again have not at the time provide formal advice on the topic. Confidentiality, privacy concerns, both sister and doctor has also covered this. As the hygienists in the workplace, which are generally not seen as part of the occupational medicine fraternity, we had to deal with temperature screening data, which can qualify as personal data. Through our risk assessments, we had to deal with vulnerable worker registers in terms of which workers cannot be or can't work in certain areas. We had to deal with lists of vaccinated and non-vaccinated workers, contact tracing, and then also long COVID surveillance data. And this became a real ethical dilemma for the occupational hygienist, whilst he or she is responsible for the risk assessment and the implementation of the findings of that risk assessment. We should not actually see individual health data. But during the pandemic, we actually had to have access to that data to ensure the safety of our vulnerable workers, non-vaccinated workers, and so forth. So the dilemma here was actually protecting the confidentiality of health and personal data of workers, and that proved to be quite a challenge and a dilemma for the occupational hygienist. So just to conclude, key learnings, I can summarize that basically in three key points: addressing inadequacies and vulnerabilities. The pandemic has highlighted existing inequities and vulnerabilities in the workforce, with certain groups facing higher risk of exposure and adverse outcomes. Occupational hygienists must advocate for fair and equitable protection measures for all workers, regardless of their background or status. As also highlighted by Dr. Jan, I think the hygienists were also put in a position where they had to make decisions and provide advice that was not always or could be deemed as fair and equitable to all employees. Ethical communication and transparency. Clear and transparent communication is essential during a public health crisis. Occupational hygienists need to communicate health and safety guidelines effectively, addressing work concerns, and provide accurate information whilst avoiding misinformation and fear-mongering. During COVID pandemic year, I think personally for the first time, I've learned the value of having a communication expert as part of our COVID-19 response. Translating scientific facts, translating complex health information into something that can be communicated to employees, to address their concerns, to put their fears aside, but also provide them effective information to make good informed decisions of their own, requires a real communication expert. And they've proven so valuable for us in our response. Upholding professional standards and integrity. Occupational hygienists are bound by professional standards and ethical guidelines in their practice. They must uphold these standards whilst navigating the complexities of the pandemic and making decisions that prioritize the health and safety of all workers. And I think this point is relevant to all occupational health disciplines. Overall, in my opinion, the occupational hygienists played a crucial but not always recognized role in protecting the health and well-being of workers during COVID-19, and addressing the ethical challenge we've identified will be essential to ensure responsible and effective occupational health management and pandemic preparedness for the future. Thank you, Adrian.
Thank you very much. And that was Professor Cass Badenhorst, our occupational hygiene expert in the room today. Thank you for your contribution, Prof. I'm now going to ask our next speaker, who will speak from the sort of broader occupational health and safety perspective, not just the sort of occupational health or occupational medicine aspect, and that is Mr. Joep Joubert. Over to you, Joep. Please proceed. If you could just check out your microphone is open, and if you could share your slides. Thanks.
Thank you, Shraf. And thanks for the invitation to speak at this webinar. It's appreciated. Is my screen visible? My voice?
Perfect. Please proceed. Thanks.
Excellent. Thank you. Yes, like I said, thank you for the invitation. And I have to make two disclaimers immediately right at the start. I looked at the situation from the safety perspective, and I interpreted certain facts or research that was done based on the safety perspective, occupational health and safety, I should rather say. Then, of course, in the process, I had to make a few generalizations. So forgive me for those. Obviously, I tried to look at a few global challenges. I looked at the specific industry challenges, and then I honed in on a few ethical dilemmas. Globally, of course, the safety guys were, and again, if I refer to safety guys, please understand that I'm referring to, in the South African context, to occupational health and safety guys and ladies. We were caught a bit unawares by the size of the threat, and in this case, I mean, we're talking about the physical size of the threat, being a virus, versus what we used to, like things such as machine guarding, etc., etc. So that was very new to us. And then, of course, the scope of the threat, in the sense that the whole of the workforce were influenced almost at once, whereas the safety people are really used to looking at more individual cases of dealing with problems. Also, all of a sudden, this was a global threat at our doorsteps. So there was no hiding place, and there was no obvious logical solution from a safety perspective. And I think the safety guys had to deal with a health issue and had to try and deal with it as a safety problem. Furthermore, this was a holistic, definitely not a one-dimensional threat, and safety found it a bit daunting because we used to tackle things one by one. Like I said, I'm making lots of generalizations here. Also, we were faced with healthcare systems being under pressure globally and in South Africa, of course. And it was something that we got the safety people really had no control over. And it makes you feel vulnerable. Also, of course, internationally, politics played a huge role in terms of preserving power for specific nations, self-preservation for nations. And in the process, safety, in some cases, sort of jumped on that bandwagon, trying to protect their turf. And that kind of approach is never really a good thing. Of course, the previous presenters alluded to this, the case of health versus freedom, and how people responded to the restrictions. And especially later in the pandemic, it cropped up as discontent from the people in the workplace, and it often fell on safety to deal with this discontent. Of course, we spoke about the communication situation, the disinformation that ran around, and everybody in management had a duty to try and make sure that the information that got to the workers, the employees, were actually accurate and not a further distribution of nonsense. Of course, it clearly showed up a global inequality in terms of government responses and the economic threat. Of course, clearly, the larger governments were easily able to deal, or the richer governments, I should say, easily able to deal with the threat, or more easily, let's rephrase. But it also manifested within the companies itself. I speak mostly from a construction perspective in this case. And you would find that the larger companies had the resources to deal with the restrictions and the prescriptions that were raised, whereas the smaller companies just could not handle that. They did not have enough resources to deal with that, and therefore it placed them in their own dilemma in this case. And just in terms of a few on a personal level, of course, I'm going to quickly squiz over this. The limitations to direct contact and social interaction was a very real issue, and especially when the people came back to site, that was difficult to contain. Of course, restrictions on movement and travel in South Africa, migrant workers was a very real problem to deal with. Of course, changes to an active lifestyle. We were restricted to very small places, and it obviously had impact on fitness and health. Boredom and monotony, and I'm quite sure quite a number of you guys know of people that started doing things which they really did not have the skills for, and therefore led to a very real risk of people potentially injuring themselves at home, for that matter. And of course, we spoke about uncertainty and people trying to find the facts, whereas in that process, they started surfing the net and were exposed to all kinds of nonsense, and they had to sift through lots of misinformation, disinformation, whatever you want to call it. In terms of specific industry challenges, and I'm saying, I speak more from a construction background. After the initial restrictions, there was some serious loss of jobs and income, and the further effect of that was, if people were laid off and the construction companies started working again, they had to, in some cases, make use of potentially unskilled people with the higher risk of incidents and safety injuries. There were obviously the strict prescriptions in terms of hygiene, distancing, use of personal protective equipment, and one of the previous speakers also alluded to that, which had cost implications for projects. And that, of course, was dealt with more easily by larger companies than small companies. Of course, there were always, especially at the beginning, the logistical challenges on the construction sites. Many construction sites do not have its own water, which was a huge requirement during the COVID period. Rotating personnel, getting the right personal protective equipment. The issue of contact tracing was an issue. Personally, I do not believe it was effective, especially later during the process, when it was not as meticulously maintained as it should have been. Also, the record keeping for tracing purposes. The value of that was a bit debatable, in my opinion. Of course, during lockdowns, we had to safeguard sites, and that proved its own problem due to people accessing sites without proper supervision, and theft and the like were the results. And of course, in terms of information, much of this hanged around the managing of the perceptions of the people. In terms of the ethical dilemmas that, in my perception, I want to raise is, firstly, especially at the beginning, we had a problem getting the right personal protective equipment. And that raised the question, if I cannot get FFP3s, can I use an FFP1, or can I use a single just a what's the right word? Lots of the guys used just cloth around their faces. Can I allow that to carry on? And could I do that and maybe counter that by trying to make other controls stricter? That was a bit of a dilemma at some places and some stages. Also with personnel rotation, that was a big thing at some point. How strictly do I enforce that personnel rotation? Or do I allow a bit more people on site? Because I know if I strictly enforce the rotation, I can only do so much in the day. And that would have an impact on the fact that this project has been standing for months already, and production is now a problem. On construction sites, we often have a space problem, and how do I manage the social distancing? Especially in the light of the fact that I know for a fact that the guys are not really sticking to the social distancing protocols in the taxis coming to site, or even at home. So that was a bit of a dilemma. Also, the fact that at the beginning we were very, very strict on cleaning regimes and those kinds of things, but at the later stage, it sort of was proven, and I put that in apostrophes, because it was never really proven. But how do I enforce cleaning regimes? Because it wastes time, it impacts on production. And then on an even more philosophical note, how does one really enforce measures he or she no longer believes, whether it's truth or whether it's perception? And then something which I also have a bit of a insight on, the moment the lockdown started, training moved from face-to-face to virtual training. And although it was a good thing and the training could carry on, there was something to do while the guys were locked down, the quality of that training in some cases was questionable. So the dilemma was, do I still issue a certificate for regulatory training such as risk assessments or firefighting, knowing full well that the person sitting on the other side is not really competent. In some cases, not even present, never mind competent. So those are a few of the ethical dilemmas from my perspective, from a health and safety mirror into more the construction environment. Ashraf, thank you very much.
Thank you very much. That was Yub Jubair. And somebody in the chat box was very thankful that you, in fact, brought this construction perspective. Our next speaker is Dr. Frank Fox, and he's presented before on one of our previous sessions, as mentioned also by Dr. Jan Lapierre. And I'm very glad that we are going to give him his 15 minutes with the permission of our attendees, which I've asked for in the chat box, and there was an overwhelming response for that. So I'm going to immediately ask Dr. Frank Fox to open his microphone and to share his slides. And then we will proceed with his input as an ethicist. And thank you, Dr. Fox, for making the time to join us and to share your experience, your knowledge, and your expertise. Over to you, sir.
Okay, thank you. Can you all hear me okay?
Perfectly, yes.
Okay, and is my screen now showing?
Yes, your slide is maximized and your video and audio is perfect. Please proceed. Thanks.
Thank you very much. Firstly, thank you to the NIOH for inviting me, and to Jan Lapierre for persuading me to do this. It's a privilege to speak to you all. Mark Twain said, I apologize for the long letter. I didn't have time to write a short one. And I think that's been a feature of all presentations today. It's also a great advantage to be speaking last, because all the previous speakers have actually given your presentation for you. So I apologize for repeating stuff that has been said before. Hopefully I can put a slightly different spin on the things. Oops, this slide is, oh, right, there we go. So we all know these 4 principles. They've been mentioned at all. They didn't change during the pandemic, and there's nothing new. Even the pandemic wasn't a new situation. It just hasn't happened for over 100 years, and we got this one when we were least expecting it, because we'd had a few false starts in the past with swine flu and so on, but this one really came at us. Although COVID was new, the ethical issues and challenges weren't, and we didn't actually have to invent approach. And I just want to recommend the HPCSA ethical guidelines to healthcare people, because they're very useful guidance. Although they're focused on clinical situations, they are very useful for all disciplines. And thank you to Sister Sishi, who actually referenced them in one of her slides. So the application in health is slightly different in different situations. At national level, there's very much a public health approach, trying to maximize the greatest good for the greatest number of people. On a regional and industry basis, it's a similar sort of approach. And at site level, even, there may be a similar approach. But then we get down to the individual application of ethics and the dual loyalties that we face in the occupational health situation of the public health measures versus the actual individual treatment of people. Some of the challenges, I mean, obviously, the previous speakers have spoken about all of these in greater length than I'm going to address them. The public good versus the individual, the legal versus the ethical. Laws are not always ethical, but they tend to be written in such a way that they must be obeyed. We mentioned the fast-moving, dynamic situation that we were in, the erratic, inconsistent, sometimes incoherent approach from government. The lockdown rules about shopping, where you couldn't buy slops, you couldn't buy ladies' underwear, but you could buy some other stuff. There was just the response from our government was really interesting to watch from the sideline. And somebody else mentioned I think it was Yup, you mentioned the bigger companies. Actually, I would like to say that it wasn't so much the rich countries that had the great advantage. It was actually the countries with competent governments that had greater advantages. Even if you didn't have the money, if you had a competent approach to it, you could get in in the line first and make sure that you got supplies. Our government response was very slow at the beginning. We ended up in a lockdown fairly quickly, but I don't think anybody had thought that through very carefully. And the slow response with regard to vaccines and testing and so on made ethical choices very difficult. And then the poor communication. Well, I hesitate to say there was any communication at one time, and we're all aware of the investigations that went on around the whole government communication approach. So none of that made our lives easy in this. In practice, we had to deal with isolation, exclusion, and quarantine. We were sitting with very little knowledge, has been mentioned already. We had situations where in the beginning, we didn't know whether this was droplet spread or contact spread or airborne. At first, masks were thought to be unnecessary and useless, and then suddenly masks were the thing to do. And then there was the whole question of what kind of mask. Is it a droplet? Will an ordinary cloth mask help? Did we need 3 layers? Did we need more highly protective masks? And obviously the focus did tend towards the more protective masks at the end of the day. But that then created shortages. And there were also shortages of tests at the beginning as well, because we didn't know, we didn't have the tests. Obviously, the situation was dynamic, and we rapidly gained access. And this is where the richer companies and the bigger companies managed to have an advantage, in that they were able to rapidly scale up PCR testing and so on. We had to deal with vulnerable people. We had to balance the rights of the individual against the greatest good for the greater number of people. Mandatory PPE, was it even worth it? Did it work? And so on. We've had mention of all these non-evidence-based interventions and remedies, but the spray tunnels, the disinfection, deep cleaning was a great financial benefit to those who jumped on the bandwagon. It really wasn't of much use at the end of the day. We had to contend with the fake news, the anti-vaxxers, mandatory vaccination in terms of how it's applied in the workplace. Was it fair? Was it constitutional? And so on. And the biggest thing really was the whole question of rationing in terms of tests, PPE, and vaccines. So basically, let's get into the lessons that we had. I mean, the big one was that ethical principles are guidance, and they're alive. No one principle is more important than the other, and they have to be weighed against each other depending on the situation that you found yourself in. Decisions had to be revisited on a number of occasions. And if I can just say this, COVID made liars of all of us, because at one time we were, the current knowledge was, yes, this works and that works, and this is what you must do. 2 weeks down the line, there'd be a study published that showed that none of what you'd said previously was true, and you had to reverse your thinking and sort of be unafraid of losing face and go back on your decision and say, sorry, I was wrong, and we have to change things again. Equity was always extremely important in the whole process here. And the one thing that really came out of this is that making local decisions requires processes, not just rules. We needed flexibility to consider the situation and not rigid applications of rules. Unfortunately, when you're dealing with the law and you're dealing with inspectorates, they expect rigid application, and that was a difficult thing for many of us. Just some thoughts on progression of the pandemic. In the early days, we had very little knowledge. The disease was severe. We didn't know about the vast majority of subclinical infections, although it may have been suspected. But we were faced with this illness that was killing people in front of us, and there was no treatment at that time. Our response was very much reactive. And the ethical focus was on public health. That was determining the greatest good for the greatest number of people, and on rationing of scarce resources. Once we got to the middle, we had a growing body of knowledge. The disease was still severe for many, many people, but there was now knowledge that we did get subclinical infections. We did get lots of mild infections that we weren't perhaps aware of. And there was a shift in our response towards proactive and preventive. And that required a shift in our approach to the ethical decisions that we made. Towards the end of the pandemic, we, I think, had a broad understanding. We had lots of surveillance in terms of new variants that were emerging, and we were able to pick up on these. We had a lot more access to testing. Most of the disease at that stage was in fact more moderate to mild, but still severe for many people at risk. There was a focus on vaccines, some relaxation of the controls. And again, that changed the ethical minefield that we were working in. But still public health with a shift towards the individual. We had to sit with situations where the company that we were advising might have said a vaccination is mandatory, but then people had the individual rights to say, no, I don't want to be vaccinated, with the understanding that if you make choices like that, there are consequences to those choices. And against that, we had a background of subclinical infections where we were excluding people from work based on test results and on exposure, on the possibility of exposure, in full knowledge that actually people were lying to us about those exposures, that many infections were in fact subclinical, and we had the infection running around the workplace while we were excluding some people because they happened to be honest with us. Right now, we're in a situation where we have an endemic disease. This is just another a viral infection. We still have growing understanding of it. The big focus these days is on long COVID and understanding that and developing treatments for it. Most infections are mild, but people are still dying of it. And we've just seen quite a lot of deaths in the USA during the winter season. It's still a significant cause of death and morbidity in the vulnerable, but we're in a situation of watching. Public health seems to be less important now, particularly in South Africa, where we should all be getting booster vaccines, but who knows where you can get a vaccine? Have we got the latest vaccine available? Is there stock? And government does not seem to have let go of the registration process just yet. We also sit with a situation where we still are required, according to the law, to isolate people if they're infected, but nobody's testing and nobody's really worried about it. So that law hasn't been repealed, and this is now, what do we do about it? Okay, so I've left some reading here for people, just as a thought. These were some articles that I found that were quite useful. And if I can give some final advice in terms of really what my talk was supposed to be about, is that in applying ethical principles, I think you've got to say, what is the situation? In occupational health, we often have dual loyalty. We have loyalties to the employer, we have loyalties to the person who's in front of us. We have to decide whether that person is a patient or a client. Are we in a clinical situation, or are we in a public health, occupational health type situation? So we need to decide, what is the situation I am? Who am I trying to protect in my interaction with this person? And in doing that, we also need to say to ourselves, how would I like to be treated? Is what I'm doing fair? Is it equitable? And is it just? And then the final question I would ask myself is, would I be happy to see my actions in tomorrow's newspaper? And would my family be happy to see what I have done? And if you can answer that question and you're happy with it, then I think you're acting ethically. Thanks, Ashraf. That's all I have to say. And I don't think I stuck to my 10 minutes either.
Thank you very much. That was Dr. Frank Fox, and I'm very glad that Dr. Lapierre had been so persuasive to ensure that you're online. Just a very quick response. The only one I'm going to read from the chat box from Sylvia Seleke. She says, very impressive where we have come from and how we've managed to put together everything with a short period of time. It gives hope that we can do better in other situations. Thank you for sharing. And Dr. Fox, Joop de Beer, Prof. Badenhorst, Dr. Lapierre, and Sister Sishi. With that note, and with Sylvia's thanks and her little note there in the chat box, I want to say thank you to everybody for your contributions, for having the time. I see that Dr. Lapierre has covered one or two very critical questions, even in the chat box. Thank you for that, Dr. Lapierre. We will obviously look for more opportunities to get into more details. We are thankful to all of our attendees for allowing us to go over time. But clearly, as we all agree, there's over 600, almost 680 people still online, that the content and the contributions of our presenters is very critical, very useful, and very valuable. And on that point, I thank you for joining us today in the National Institute for Occupational Health, the NIOH's webinar, Ethical Dilemmas in the Workplace During COVID-19. And if you have any burning questions beyond our closure now, please send them to info, that is info, INFO, at nioh.ac.za. And as a reminder, Dr. Chin, part of our organizing team, has asked me to mention that the full recording of this webinar will be made available to you. The link will be circulated to you, as well as the PowerPoint presentations will be uploaded onto our website, and the links will be available to you. And for those who've asked the questions about CPD points, we've got one ethical CPD point being processed. And as once that is done, you will have to do the online CPD test. The link we will send to you as well. Thank you. Goodbye. See you on our next webinar.